Our program was built to address the issue of access to buprenorphine for patients who've been diagnosed with opioid use disorder. It's important when we talk about access that we're not talking about just unfettered access with no restrictions. Whenever you're talking about a controlled substance, it's important to talk about access in the context of the appropriate controls, the proper controls in place. And Demetra will talk a little bit about that here in a minute as well. But our program is really based on the feedback that we've gotten from patients and clinics over the years. And really before COVID-19, our program had really gotten very popular. It was growing very, very fast in Q1 of 2020 and through March and into April here as the epidemic has, or pandemic, I should say, has come here. But the pandemic also has created a lot of new challenges that for treatment centers and patients. And they need solutions now more than ever. And the feedback we've gotten from these groups over the last several years of doing this have really fallen into three different buckets. So this is both before COVID-19 and now. The first bucket, and most common thing we've heard from patients and clinicians, is just stigma. Stigma and judgment. And unfortunately, stigma and judgment have always been a part of the disease of addiction. Patients often complain to us about either perceived or real stigma that they felt when going to a pharmacy to get their medications filled. They felt like that they were treated poorly at times, or that they just there was a bias against them as a patient. And even clinicians would get frustrated because of pharmacies and pharmacists questioning their treatment plan, not really understanding buprenorphine or being up to speed on it, but then questioning it, having a bias against the drug, or even against the prescribers who prescribe the drug. And now we have that still exists today. And then on top of that, you have the issue of sending patients into what's potentially a busy or crowded pharmacy, the stress of potentially being exposed to COVID-19 just continues to make that problem worse. The second thing that we would hear from patients is just transportation barriers. And we know these are very real for this patient population, that they struggle with public transportation. A lot of them use transportation as provided maybe through their Medicaid provider. They get rides with friends, but in general, just that they're challenged when it comes to transportation. Now, many of them, during the pandemic here, public transportation has been pulled back. Various resources have been pulled back, and they're not even supposed to be in a car with somebody else unless it's a direct family member that they live with. And it's just made the transportation issue that much more difficult. In fact, we were just onboarding a new client in the Kentucky area, and we had part of the onboarding process is we talk to the patients about the program and how it works, which we'll cover here in a second. And we had a patient really choke up and brought to tears because of how challenging it was. Every time they went to see their provider, they'd leave with a prescription, and they would spend the rest of the day working on how to get to the pharmacy and dealing with the challenges there. And that this program removed all of that for them, and what a difference it was going to make in this person's recovery and their life. And then the third thing we hear is just difficulty finding the medication in general. So it being out of stock, or pharmacies not carrying enough of it. So they would go to get a prescription filled and have to wait a day to get it filled. Or we even heard in some areas about pharmacies putting limits on the number of addiction patients they would take. So once they had 25 or 50 addiction patients getting their prescriptions filled there regularly, they became full. They wouldn't take any more addiction patients, which is really unfortunate. We wouldn't treat any other disease state that way. But for some reason, again, the stigma and the judgment that comes with addiction, these things tend to happen. But these three things are all very real issues that have only been exacerbated by the pandemic. So whether you're seeing patients in your office or whether you're doing telemedicine or some combination of both, this program can be implemented. And I'll go through it very quickly at a high level, and you'll be able to see kind of as we go through how it diverges based on if you're doing in-office care or if you're doing telemedicine. So a couple important points about our program is that typically when a clinic treatment center starts utilizing our program, the vast majority of their patients will enroll in our program. They're not forced to enroll, but there's an education process that we go through, an onboarding process where we tell the patients about the program, or the clinician tells the patients about the program, and then they can opt in or out. Typically, we work with anywhere from 80 to 100% of a particular clinician's patient population. And when I say patient population, we're talking about MAT medications, buprenorphine specifically. And you'll see why patients will want to do this here in a second. So, and then for the in-office program, we put an agent of the pharmacy actually on site at the clinic. So we're not opening a pharmacy on site, but we have a person on site who represents the pharmacy, who reports into the pharmacist, to help with the delivery of the medication. And I'll explain that here in a second. But so when somebody enrolls with us, their patients are educated on our program. The ones that opt in, their prescriptions are sent to us, either e-prescribed, or they are sent via FedEx, or we have other means in which we can get the prescriptions. They come to us a few days before the patient is actually due for their medication. When they arrive at our pharmacy, we do a series of checks on this prescription. So we check the state PDMP on every single patient that we dispense for every single time we do a dispensing. We review for insurance eligibility. We speak to every patient as well, so we get an interaction, making sure they don't have questions about their medications, but also gives us an opportunity to interact with that patient. And then if someone's doing laboratory testing with us, we also can review the laboratory results, the drug screen results specifically. So if there's any issues there, we can raise that and have a consultation with the clinician. So if any irregularities pop up, we will reach out to the provider and we'll talk through what the right next step is for that particular patient. Otherwise, we're going to offer our naloxone program to the patient. We're going to offer our drug take-back program to every patient as well, because if we can help eliminate some drugs on the street, that's great. And also, we feel it's really important to put naloxone in everybody's hand who's at risk. And now the next step is about getting the medication to the patient. So in our traditional program, let's say pre-COVID-19, prescriptions were typically sent directly to the patient in coordination with the patient's office visit. And so clinics who are still seeing patients, that's what we do today. We have an agent, or what we call a pharmacy coordinator, on site at the doctor's office. The medication for the day, for patients who are coming in that day, is sent directly to that pharmacy coordinator. They either go by and pick it up on the pharmacy on the way in. They have it brought to them via courier or via FedEx. They get the medication, they store it securely at the clinic, and then patients come in for the day. And if they come in, they have an appointment on April 16th. They go and they see their clinician. Maybe they go into the next room, they do counseling, they do their group session, whatever reason they're there. And then they'll walk into the next room, and our person will be there, our pharmacy coordinator. And we check their ID. We have their prescription for them. It's in a white bag, a bottle of tabs or films based on what they're being prescribed, with their name on it. It's already been adjudicated and fully dispensed. Patient signs off on it. We get the receipt. They take their medication, and they're done. And they can walk out the door. They don't have to make that extra trip to the pharmacy. They don't have to deal with the other barriers they've had to deal with in the past. Now, with telemedicine, we also do home delivery. So now, instead of patients coming in with all the social distancing and shelter-at-home rules in place, a lot of times patients either aren't comfortable coming in, or they're under quarantine, and so they're doing telemedicine, in which case we can coordinate a home delivery for that patient. We reach out to the patient, we coordinate a home delivery, we can collect copays over the phone, that sort of stuff, and send the medication directly to the patient when they're due for the medication. And then finally, a lot of data is able to be given back to the prescriber as well. So for our clinicians who use us for pharmacy, as well as laboratory in particular, we can give down to the patient level integrated data, both pharmacy and laboratory data, looking at medication possession ratios, how many uninterrupted days of medication does this patient have, what are their drug test results look like, and to put that out longitudinally, as well as give population data back to the clinic as well, and looking at their population as a whole. But at the end of the day, patients love our program because it really promotes patient safety. These days means they can stay at home. They don't need to go into a busy pharmacy or whatever it may be. They have a great patient experience. I think that's one of the things that really sometimes we underestimate, is that they get to work with a pharmacy staff that we deal with addiction patients all day. That's what we do. Our team is a dedicated group of professionals who are really passionate about helping individuals with opioid use disorder overcome these barriers and help to reclaim their lives. And our people get to hear the stories and how much of a difference this program has made for these patients. And it's really motivating and inspiring when you get to hear those things. So I know I just spoke for a while. So Demetra, why don't, if you want to talk about the program from a regulatory perspective.
Exactly. So from a regulatory standpoint, I just wanted to point out a couple of things Bob mentioned about the in-office delivery. So the Controlled Substances Act, and that's the law that authority that the Drug Enforcement Administration that they have to enforce laws, Title 21. And in that law, there individuals, businesses that handle controlled substances, manufacturers, pharmacies. In this case, we're speaking of a pharmacy. They have to be registered in order to handle controlled substances. So, but there are 3 exceptions to handling controlled substances, 3 manners in which you don't have to be registered. One is if you're an employee. Let's say you're an employee of a pharmacy or a manufacturer or distributor, you don't need a DEA registration. If you are a common carrier, delivery person, UPS, that type of thing, even a delivery person for the pharmacy, you don't require a DEA registration. And then there's also the ultimate user, of course. So in Cordant's delivery in-office process, we would fall have been the delivery person for the pharmacy. And that would make them exempt from having a DEA registration and able to legally hold, possess controlled substances in order to deliver to the ultimate user. So in that model, the pharmacy coordinator within the pharmacy delivers directly to the patient. The physician in the physician's office, the physician's staff, they never handle the controlled substances. The controlled substances are safe and secure with the delivery personnel, and until it's turned over to that individual or the designated recipient that they authorize, until it's handed over to that individual, then they are in compliance with the Controlled Substance Act. And Bob, can you explain to them what happens if that person doesn't show up, if they don't show up for their appointment?
Yeah, no, that's great, because we send the medication ahead of time. So it gets there either courier or delivery the day the patient's supposed to be there. So occasionally we deal with patients who don't show up, although we'll show you some data in a minute that explains why that gets better with our program. But if a patient doesn't show, it's not a big deal. We deal with this all the time. We keep the medication securely stored with our pharmacy coordinator. And at the end of the day, that medication gets shipped back to the pharmacy. Nothing ever stays overnight. And we unwind the claim, insurance claim, if there's insurance involved and all of that. So it's a really simple process at the end of the day. And the same applies, like if there's a dosage change, we can unwind the claim and send it back, or other things that just make the delivery not possible. So as I mentioned earlier, this fits really well into telemedicine too, because we can deliver the medication to the patient's home. Demetra, why don't you talk a little bit about the new exceptions that SAMHSA and the DEA put in place to try to facilitate and make telemedicine a little bit easier?
So DEA and SAMHSA, they worked in partnership to using their authority to be a little flexible in these difficult times. So in the month of March, and a couple came out in April, and I would encourage you to take a look at DEA Diversion website. It's at the bottom of the slide here, and also SAMHSA.gov, because they're updating every day. I think they started with the first one around the 16th or so of March, and in the last one I saw, I think it was dated April 9th. So they're making changes and being flexible to accommodate registrants, those that handle controlled substances. So these are 2 important ones I wanted to pull out for you. There's several more, and again, I encourage you to take a look at the website. So these 2, in regards to telemedicine, the 2 important things that changed here are, the data wave. Physicians can now prescribe without giving that first face-to-face in-person evaluation. So you can do it, and they've made the allowance that you can do it via telephone. And this is just a voice telephone call, where telemedicine is typically over an audio-visual smartphone, Zoom meeting, or something like that. But what they've allowed for buprenorphine treatment for patients is just a voice telephone call, even for onboarding new patients. So that's pretty significant. And I want you to know that this is granted just through the duration of the public health emergency. Again, check the website, because situations, they change. And the other pretty significant allowance that they made is for the physician to, even if you're in another state, a physician who is licensed, let's say I'm in the state of Illinois, a physician would normally be required, if he were to prescribe in Indiana, to have a license in Indiana. They have waived that. So if you have a DEA registration in the state of Illinois, you can practice in other states in the country as long as you have a valid, active state and federal license in the state in which you reside. Those allowances, or there's exception, is also allowed for telemedicine. Prior to March 23rd, 2020, if you were to practice telemedicine across the country in California, a physician in Illinois would need to have a DEA registration in the state of Illinois and also a DEA registration in California. With this exception, you have your license in the state of Illinois, you can practice telemedicine and treat patients in California. So that's the simplest way I can explain that. And and again, I encourage you to check the website. They are they're being very flexible and granting exceptions and working with industry. And another thing, I was talking to a former colleague earlier today, if you have questions, they are responding fairly quickly to emails, just, within a week, which is, almost unheard of when it comes to regulatory authorities. But feel free, you should do that sort of thing too, to get questions and clarification on any questions you may have.
Great. I'm going to jump in real quickly and just talk a little bit about the results that we're seeing in our program. So what we're going to reference here, this is from the pilot group that we work with. So as we launched this, we set up to be able to capture certain data points that we believe that our program would have an impact on. And then there was some data that we were able to capture that we didn't realize we'd have an impact on, that it appears that we were able to impact. So what this is comparing is two groups of patients. So first is a group of patients prior to our implementation of our on-site distribution program. So the same practice, set of patients before we implemented the program, what were their statistics? And then looking at a second cohort of patients of after we implemented our program, what did this set of patients look like? So we found some really significant things. So first off was a 52% improved retention rate. So patients who were using our program, getting their medication in the office, were more likely to stay in treatment 6 months, still be in treatment 6 months later. And we saw that across all different patient types, but where we saw the biggest difference, the 52% improvement, was in newer patients. So patients who were still in their first day to their 90th day of treatment. So if they had just started treatment, day 1 to day 90, and they were in our program, they were 52% more likely to still be in treatment and successfully in treatment 6 months later. And for any of you who run treatment centers or MAT centers, you know the churn that happens within the patient population there. And we're seeing that our program can help reduce that and help keep people in treatment and successful in treatment. We saw 32% fewer no-shows. So patients were just more likely to show up for their appointment if they knew that their medication was going to be there. We saw a 43% reduction in emergency room or drug-related emergency room visits. So not like I broke my arm, but things like doctor shopping behavior, overdoses, things like that went down 43% for this patient population. We saw a 44% reduction in relapse events that we measured through drug test results. So it's sometimes hard to always capture all of the relapse events in when going through EMRs, but we did it through drug testing. And so if somebody tested positive for an opiate or positive for an illicit drug, that's what we counted as a relapse event. So we were using subjective data, or I'm sorry, objective data there, just as a measuring point. But again, we saw 44% fewer positive opioid tests or relapse events. And then finally, just patient feedback. We do a regular patient survey out to our patients and just get their feedback. And we average 5 stars easily. And just the words that they use when talking about our program are just amazing. And I've been able to sit down and talk to patients, and through my time here working with several, the large number of groups that are using us now, several dozen groups using us now with this program across the different states, and listen to patients talk about how much of a difference this makes for them, how they love the stigma-free environment, the judgment-free environment, how convenient it is, the privacy of it. All of these things have just made a big difference for them in their road to recovery.